Bismillah ar-Rahman ar-Rahim. This presentation is entitled Maxillofacial Trauma, as it is important to the dental students, where we will be discussing some of the facts that applies to maxillofacial trauma. Now, before we start, I should warn all of you who are watching this video that this is not intended to dismiss class attendance. This is not replacing a lecture and is not guaranteed to cover the whole required knowledge and skills from you. Maxillofacial trauma, injuries to the face by their very nature, impart a high degree of emotional as well as physical trauma to patients. The science and art of treating these injuries requires special training involving a hands-on experience and an understanding of how the treatment provided will influence the patient's long-term function and appearance. Now, there are a number of possible causes of facial trauma. As you know, motor vehicle accidents are incrementally increasing, with accidental falls, sports injury, and interpersonal violence as some of the examples. Soft tissue injuries of the maxillofacial region, when this occurs, it can involve the skin and gum. It can involve special areas in the region of the maxillofacial territory, and this includes the eyes, facial nerves, and salivary glands. And of course, trauma can result in fractures in one or more of the facial bones. So the maxillofacial surgeon should be ready, equipped, and trained to treat injuries to teeth, mouth or oral cavity, jaws, and facial structures. This is a common example that we see as a neurosurgeons in the emergency room of any hospital. Now, the patient is showing trauma to the head and maxillofacial structures resulting in fractured bones, but the maxillofacial surgeon should work in proximity with the neurosurgeons, knowing that the most important and count is the brain. In facial and mandibular fractures, one should remember that bones of skull and face collectively make up the most complex area of the skeleton, and that analysis of the fractured face requires a knowledge of not only normal anatomy but also of common fracture patterns in the face. Here we see some of the commonest types of fractures. Almost 40% of the fractures occurring in this region are of the tripod fracture. Another 35% is collectively going to the types of LeFort fracture 1, 2, or 3. The rest are of separate single bone fractures that may involve the zygomaticomaxillary, the alveolar process of the maxilla, and sometimes smash fractures. The tripod or zygomaticomaxillary complex fracture is probably the most common facial type of fractures, and it is so called because it involves separation of all three major attachments of the zygoma to the rest of the face. Although it may be fractured, but the separation of the frontal process of the zygoma from the frontal bone, as appearing here, usually occurs in the form of diastasis of the suture itself. This fracture is usually due to a direct blow to the body of the zygoma, and the fracture will generally cause contour abnormality, causing some visual problem, and that's why CT scan of the region is extremely helpful. Occasionally, extraocular muscles may become entrapped in the component of the fracture complex. Another common type of injury is the blowout fracture that is involving the orbital floor. The usual mechanism is a blow to the eye, with the forces being transmitted by the soft tissue of the orbit downward to the thin floor of the orbit, as shown in this figure. And then the fractures will downward into the maxillary sinus as well. Thus, common clinical signs are enophthalmos and diplopia, especially when the patient upward gaze. And one should remember that about 1/3 of these fractures are also associated with ocular injuries. Now, pure LeFort complex fractures are rare, and they are commonly associated with other multiple midface fractures. By definition, classically, a LeFort fracture represents symmetrical fractures on the right and left side of the midface. And as we said, these are rare, and the more commoner are a hemi or on one side of the face, and that's why clinicians, maxillofacial surgeons, usually use a terminology that is called hemi LeFort fracture, when the fracture is present on one side only of the midface. In LeFort I, or transmaxillary fracture, runs between the maxillary floor and the orbital roof, and thus it is also known as a horizontal maxillary fracture. It may involve the medial and lateral walls of the maxillary sinuses, and invariably may involve also the pterygoid process of the sphenoid bone. Clinically, the floating fragment will be the lower maxilla with the maxillary teeth. This is a 3D CT scanning showing clearly in the two examples the line of fracture across the or horizontal across the maxilla. In the LeFort type 2 fracture, the fracture line occurs along yet another weak zone in the face and is sometimes called a pyramidal fracture because of its shape as seen in this diagram. A common mechanism is a downward blow to the nose. The fracture is shaped pyramidal. It involves the pterygoid region, and the line is underneath the zygomaticomaxillary line. The most severe of the classic LeFort fracture complex is the LeFort III, and I suppose that this is pretty obvious given a three-part grading system. In this case, the large unstable, or sometimes we can call it floating fragment, is virtually the entire face. Thus, this fracture is also referred to as craniofacial dissociation. This is a very serious and severe injury and is often associated with significant injury to many of the soft tissue structures along the fracture line. In managing maxillofacial injury, although they represent serious injuries, the workup and treatment of facial fractures is often probably delayed until more pressing problems have been addressed, such as the establishment of an adequate airway, hemodynamic stabilization, and the evaluation and treatment of other more serious injuries of the head, chest, and skeleton. Once these problems have been managed, it is then time to work up facial fractures. At our institution, high-resolution CT scanning is currently the imaging procedure of choice for most facial fractures. But regarding plain X-ray imaging, a basic facial series should consist of 3 or 4 films: a water view, PA view with cephalad angulation, a caudal view, which is a PA view, a lateral view, and occasionally we order a submental vertex view. In addition, if a nasal fracture is suspected, then a lateral view of the nasal bone with a special nasal technique may be done. In addition, being a maxillofacial surgeon working in a teamwork with the neurosurgeons, I urge you to know what is a Glasgow Coma score and how do we apply it to evaluate on the patient consciousness. This includes a 3-tiered score involving the eye opening, the best motor response, and the best verbal response. This is an example of a road traffic accident where the driver was not having his seat belt on. He had a direct acceleration-deceleration type of injury where he hit with his face the windshield. This resulted in not only injury to the maxillofacial region, but to intracranial compartment injury involving several cerebral contusions and hemorrhages. This CT scan of the head is showing a patient after being involved in trauma to the head and resulting in a epidural hematoma characterized by being a lens-shaped or biconvexity. The previous type or epidural hematoma should be differentiated from this type of hematoma that is called subdural hematoma, and this one is characterized by having a concave shape taking the whole shape of the brain or the curvature of the brain, and this is an intraoperative imaging of the patient after we open the dura and the hematoma being evacuated. Now, in the management of maxillofacial trauma, after, of course, as we said, stabilizing the patient with all serious injury, whether it is neurological, cervical spine, chest, abdomen, and so forth, then we start addressing emergency related to the maxillofacial trauma itself prior to definitive trauma. These include, for example, airway compromise and excessive bleeding. If the airway is compromised and the orotracheal intubation cannot be established, the midface complex may be impacted posterior-inferiorly, causing obstruction. This impaction may be attempted manually or with large disimpaction forceps around the alveolar arch and pre-maxilla. If the segments do not move readily and the airway obstructed, an emergency tracheostomy may be necessary. Severe bleeding may occur from soft tissue laceration, or intranasal structures. and a combination of pressure, packing, cauterization, and suturing may be useful in such situation. After that, fixation of unstable fracture segments to stable structures is the objective of definitive surgical treatment of maxillary fractures. This principle, while seemingly simple, becomes more complex in patients with extensive or panfacial fractures. The stabilization will involve different and multiple shapes and sizes of microplates and screws. Now, the job of the maxillofacial surgeon did not finish by that. On the contrary, the post-operative period is an important part. So to minimize post-operative edema, a light pressure dressing consisting of gauze and a head wrap may be applied to the place of the operated area. If the dressing remains dry, then you may remove it after 2 to 5 days. Regarding the antibiotic utilization, people differ in their opinion. In general, if the fracture is open to the external environment or in communication with intraoral or intranasal spaces, then you may implement prophylactic antibiotic covering both gram-positive aerobic as well as anaerobic organisms for 5 to 10 days. After surgery, the patient should be observed overnight for bleeding, airway problem, and vomiting. And for this, which is the risk of vomiting, if you applied wire fixation, then always place a wire cutter near the patient bed at the early post-operative period, so that if the patient is having an attack of vomiting, you should immediately advise for removal of the wiring. Finally, remember that trauma might be iatrogenic. In other words, you, as a maxillofacial injury, avoid having complication to your patient. Take this as an example. This is a young boy who went for his regular dental visit, and the dentist started working on his caries by giving a local anesthesia. Now, look carefully at the face of the boy and figure out what is the problem. Those of you who said that on the right side there is a lower facial nerve palsy are correct. But figure out what is the underlying pathology or underlying pathophysiology behind this facial palsy. Remembering your anatomy is extremely important and helpful. Remember that the parotid gland encases the facial nerve, and that the capsule that surrounds the parotid gland also extends along the inner and outer part of the masseter muscle. Thus, if you are injecting your local anesthetic to the patient and you were not that careful, the needle will traverse through the capsule, and when you inject the local anesthesia, it will infiltrate along the capsule and thus will reach the facial nerve. This will lead to facial nerve palsy of lower motor neuron type. Most of the time, it is temporary and the patient will have a relief in 2 to 3 days. But sometimes cases have been reported to be permanent damage to the nerve, and that's why you have to be careful when you are dealing with your patients. With this, we come to the conclusion of the lecture, and I thank you for your attention. I also advise you that you may have more educational films on my website and YouTube channel. Thank you.